Hello friends. So after discussing about the CNS tumors, now let us discuss some of the conceptual and clinical questions in this topic, and let us see whether we can answer those questions or not. Now let's start with the first question. A 45-year-old woman has had unilateral headaches on the right side for the past 5 months. Physical examination yields no remarkable findings. The representative gross appearance of the lesion seen on the CT scan of the head is shown in the figure. So this is the gross image. Okay, and this is the tumor, of course. Now the mass is surgically removed, and microscopic examination shows elongated cells with pale oblong nuclei and pink cytoplasm with occasional psammoma bodies. And the cytogenetic shows 22q deletion. 22q deletion. What is the most likely diagnosis? So from this image, you can understand that this is a tumor. It's an extra-axial tumor, and it has a dural base. So it is arising from the dura. So it's a dural-based tumor. And when they did histopathology, they find this psammoma body. Psammoma bodies are concentrated, laminated calcifications, and these are known as the psammoma bodies. And these psammoma bodies are found in meningioma. Okay, so meningioma, it's a dural-based tumor, and in the histopathology, you will find this psammoma bodies. So these are the psammoma bodies. Okay, so answer is meningioma. Cytogenetic, so 22q deletion. So basically, 22q contains the Merlin gene. The Merlin gene, and this is most likely mutated in patients with meningioma. Merlin gene mutation is also associated with neurofibromatosis type 2. Okay, so meningioma is also a component of neurofibromatosis type 2. Coming to the second question, a 39-year-old HIV positive man has received no antiretroviral therapy. He has had left-sided weakness for the past month and experienced a generalized seizure a day ago. On physical examination, he is afebrile. Afebrile means they are telling a condition which is probably non-infectious. The CT scan of the head shows no intracranial hemorrhage, but there is a midline shift. MRI of the brain shows 4 cm mass in the region of putamen near the right internal capsule, a 3 cm mass in the right centrum semiovale, and a 1 cm mass near the splenium of the corpus callosum. That means it's a multifocal tumor. Okay, so multifocal lesion. And as you can understand that all these are surrounding the ventricles. So periventricular multifocal lesions, these masses are circumscribed and solid. CSF from the lumbar puncture shows an elevated protein concentration and normal glucose level. Cytologic examination shows large cells with large nuclei and scant cytoplasm. So large cells, large nuclei and scant cytoplasm, and they're marked with CD19. So basically, they want to tell us about a B cell neoplasm, that is DLBCL, diffuse large B cell lymphoma. Okay, diffuse large B cell lymphoma. These are negative for GFAP and cytokeratin. That means it is not glial cell origin. It is CD19 positive. That means it's a B cell. CD19 is a B cell marker, so the B cell origin tumor. So they are telling us about the diffuse large B cell lymphoma, which is present in the periventricular location and in a patient who is having HIV. So basically, they want to tell us about primary CNS lymphoma. So these are all the features of primary CNS lymphoma. Untreated HIV patient with periventricular multifocal mass lesions, and cytology is showing CD19 positive cells. Okay, so as you can see in this image, so they tend to involve the periventricular region. Okay, so I have not discussed about primary CNS lymphoma in my previous video, so this is one new thing you can remember. Okay, so what is the answer? What is the most likely diagnosis? CMV encephalitis, no. Glioblastoma, no. Kaposi sarcoma, no. Yes, large B cell lymphoma. So answer is large B cell lymphoma. Now coming to the next question, a 76-year-old man has a single episode of grand mal seizure. On physical examination, he is afebrile, normotensive. That means there is no infection. Motor strength is intact and there is no loss of sensation. Cranial nerves are intact. His mental function is not diminished. There is a 1 cm darkly pigmented skin lesion in the upper back. Okay. So the patient is having a darkly pigmented skin lesion in the upper back. Brain MRI shows 3 solid 1 to 3 cm mass lesions without ring enhancement or surrounding edema, located at the gray-white junction in the right and left frontal lobes. Okay. So this point is important. Gray-white junction. So whenever in the CNS, they are telling you about the gray-white junction. So you have to think of metastatic lesions. Okay. So CNS mets are they are usually located at the gray white junction. So these are multifocal and they are located in the gray white junction. CNS mets also I have not discussed in my previous videos. So this is again one more new concept. Now you should remember. Okay. So gray white junction. So it is metastasis. Now, then what is this darkly pigmented skin lesions? So you have to remember that skin cancer, that is melanoma. Melanoma has a tendency for CNS metastasis. They have tendency for CNS metastasis. So most likely this lesion is melanoma, which is causing CNS mets, and that is producing multifocal lesions in the gray-white junction. Okay, so answer is metastatic carcinoma. So most likely diagnosis is metastatic carcinoma, and the primary is melanoma. Okay, so usually the metastatic carcinomas, the imaging will be like this. As you can see here, these are multifocal lesions. Multifocal lesions, they are present in the gray-white junction, gray matter, white matter junction. Okay, and one more point you have to remember that if they ask you what is the most common CNS tumor, it has to be METs. Okay, so secondaries are the most common CNS tumors than the primary. Okay. Now coming to the next question, 18-year-old student had decreased vision in the right eye for 6 months. On physical examination, there is papilledema on the right. She has 14 scattered 2 to 5 centimeter flat hyperpigmented skin lesions with irregular borders in the extremities and torso. So hyperpigmented skin lesions. So these are actually cafe au lait macules, cafe au lait spots. CT scan of the head shows no intracranial hemorrhage, no edema or midline shift, but there is a mass in the region of right optic nerve. Okay, so this is right optic nerve glioma. Optic nerve glioma. Okay, 8 months later, she returns for a follow-up examination, and a mass is palpated in the right wrist. Okay, so we are able to palpate a mass in the right wrist. Now, histological examination of this mass is most likely to show which of the following neoplasm. So, from cafe au lait spots and optic nerve glioma, now you have understood we are discussing about a case of neurofibromatosis type 1. Okay, so this is, you can see here, this is a optic nerve glioma. So this is classically seen in neurofibromatosis type 1. What other features we are going to get? We are going to get cafe au lait spots. We are going to get Lesch nodules, axillary freckling, and neurofibromas. So all these things we have already discussed. So in neurofibromatosis type 1, you are going to get all these features. So answer to this question is fibrosarcoma. So here answer has to be fibrosarcoma. Okay. So it cannot be lipoma, it cannot be hemangioma, it cannot be meningioma, it cannot be schwannoma. So it has to be fibrosarcoma. So neurofibromas can be converted to fibrosarcoma. Okay, so that is the answer in this question. Now, next question is 41-year-old old woman has had diminished hearing for past 4 months. On physical examination, she has decreased hearing on the left side. Sound lateralizes to the right ear on Weber tuning fork test. Just forget about it. Then the head MRI shows sharply circumscribed 4 centimeter mass adjacent to the left paunch that extends toward the left inferior cerebellar hemisphere. So that means there is a tumor at the cerebellopontine angle. Okay. So tumor at the CP angle, cerebellopontine angle, and it is associated with decreased hearing. So they are telling us about acoustic neuroma or vestibular schwannoma. Okay. A smaller 1 centimeter lesion is in a similar location on the right side. That means they're telling us about bilateral acoustic neuroma or bilateral vestibular schwannoma. Okay, so these things we have already discussed, and I have told you whenever there is bilateral vestibular schwannoma, you have to think of neurofibromatosis type 2, which is caused by mutation in the gene Merlin. Gene is Merlin, and the chromosome is chromosome 22. And I've also told you neurofibromatosis type 2 is also associated with meningioma. Okay, and there is one more tumor, that is ependymoma of spinal cord. So these are the 3 tumors that are associated with neurofibromatosis type 2: meningioma, schwannomas, vestibular schwannomas, and ependymoma of the spinal cord. So answer is neurofibromatosis type 2. One more point they have given here: family screening reveals a similar affected 38-year-old sibling. Okay, so this is basically a autosomal dominant condition. So almost all the neurocutaneous syndromes are autosomal dominant except the Sturge-Weber syndrome, which is not inherited. As you can see here, there is bilateral vestibular schwannoma in the cerebellopontine angle, and they are producing the classical ice cream cone appearance. A 20-year-old woman with learning difficulties had flank pain for 1 week. Flank pain means there is some problem in the kidneys. So physical examination shows right posterovertebral angle tenderness, patches of leathery appearing and hypopigmented skin lesions. So basically, they have already given in the question that you are going to get saccharine patches and as-leaf macules. Okay, so even if you don't read the rest of the questions, your answer has to be tuberous sclerosis. Because in tuberous sclerosis, you are going to get the saccharine patches and as-leaf macules. But now, let's just finish the question. There is a subungual nodule in our right index finger. That means subungual fibroma. Abdominal CT scan reveals bilateral renal cysts and tumor masses. So I have told you in tuberous sclerosis, we are going to get cysts in the kidney, in the liver, and in the pancreas. MRI of brain shows subependymal nodules. So in tuberous sclerosis, in the brain, you are going to get cortical tumors, subependymal nodules, and subacute giant cell astrocytoma. Sorry, subependymal giant cell astrocytoma. Okay, and subependymal giant cell astrocytoma, sometimes it can go into the ventricles, it can block the CSF flow and can cause hydrocephalus, and that is what is given here. So it is causing hydrocephalus. Okay, so answer is tuberous sclerosis. So this is the R-sleeve macule, the hypopigmented macule, and this is the saccharine patch. This is localized leathery thickening. This is subungual fibroma, and these are the cutaneous angiofibromas. A study of adults with cerebellar neoplasms reveals that some of them have an autosomal dominant inheritance pattern with von Hippel-Lindau disease. Their cerebellar tumors are cystic with a mural nodules. So what is the tumor that you are, what is the CNS tumor that you are going to get in von Hippel-Lindau disease? That is cerebellar hemangioblastoma. Okay, so that we have already discussed. Cerebellar hemangioblastoma. And I have told you cerebellar hemangioblastoma will have a cystic component, will have a mural nodule. So that is what they have given here, cystic with mural nodule. Molecular analysis of the tumor cells shows increased amount of hypoxia inducible factor. So I have told you what is the normal function of what is the normal function of von Hippel-Lindau gene? So normal function is they will ubiquitinate and ubiquitination and proteasomal degradation of the HIF alpha. So if there is a mutation in the VHL gene, there will be increase in hypoxia inducible factor. The incidence of RCC is increased in these persons. This we already know. Von Hippel-Lindau disease increased incidence of bilateral clear cell type of RCC. Which of the following paraneoplastic? They are asking about the paraneoplastic manifestation in this disease. So I told you that whenever there is increased hypoxia inducible factor, there will be increased expression of hypoxia related genes. And among these genes, there is a gene that is known as erythropoietin. Sorry, there is a protein that is known as erythropoietin. So erythropoietin will also be produced in excess, and this will cause erythropoietin will cause increased hemoglobin production. So there will be secondary polycythemia. Secondary polycythemia. So answer has to be polycythemia. Okay. And here you can see the imaging. You are having a cyst and a nodule. So this is a cerebellar hemangioblastoma. A 12-year-old child brought to the emergency room by his parents because he is complaining about not being able to see correctly. An examination reveals bilateral temporal defect in the visual field. So basically, this child is having bitemporal hemianopia. Bitemporal hemianopia. Okay, and a CT scan of the head reveals a mass that has some calcification. So bitemporal hemianopia plus calcification. So what is the most likely diagnosis? Okay, so by this time you must have known that the answer is craniopharyngioma, because pilocytic astrocytoma, this is found in the cerebellum, so it cannot cause a visual defect. Medulloblastoma again cerebellum, ependymoma again. Medulloblastoma is in the cerebellum, ependymoma in the ventricles. Oligodendroglioma, usually they involve the frontal lobe. So answer has to be craniopharyngioma, which is a supraciliar tumor, and it can actually block this. Optic chiasm. Okay, so because of the blockade of this optic chiasm, they will have bitemporal hemianopia. So this I have already discussed. Okay, and this craniopharyngiomas, especially the childhood craniopharyngiomas, these are otherwise known as the adamantinomatous craniopharyngiomas. They will have calcification. A 13-year-old child is brought to the emergency room by EMTs because he had a seizure during breakfast, which was witnessed and reported by his parents. CT scan of the head reveals a mass in the left cerebral hemisphere, which is subsequently excised by neurosurgeon. Okay, so it is a boy. It's a childhood tumor, and now in the histopathology, you are getting numerous Rosenthal fibers. I hope you remember what are these Rosenthal fibers. I'll tell that again. And also these tumors are GFAP positive. GFAP is the glial fibrillary associated protein, and these are positive for all the gliomas. And these are the Rosenthal fibers, as you can see here. These are nothing but the eosinophilic, tree-shaped, elongated structure. So eosinophilic elongated structures inside the astrocytes. Okay. So these are known as the Rosenthal fibers. These are made up of alpha beta crystalline, HSP27 plus ubiquitin. Okay. So these are the components of Rosenthal fibers. These are the eosinophilic corkscrew-shaped elongated structures inside the astrocytes, and these are classically found in pilocytic astrocytoma. So this child is having pilocytic astrocytoma. Okay, but you have to remember that Rosenthal fibers are not specific for pilocytic astrocytoma. They can be seen in any condition associated with long-standing gliosis, and they can also be seen in Alexander's disease. Okay. This is actually low power image of the pilocytic astrocytoma. You can appreciate that there is a hyperdense area and there is a hypodense area. Hyperdense area means there is increased cellularity. In the hypodense area, you will get the microcysts. So you will get cysts and microcysts. So that is less cellular compared to the hyperdense area. So this is the biphasic appearance of the pilocytic astrocytoma. Okay, so pilocytic astrocytoma, you are going to get biphasic appearance. And if you see in the high power image, you are going to get the Rosenthal fibers. So answer is pilocytic astrocytoma. I have told you pilocytic astrocytomas, childhood tumors, they have a very good prognosis. They will not metastasize. They are localized tumors. They will not infiltrate. They will not metastasize. So what will be the answer? It has a poor prognosis? No. It has a good prognosis. It commonly produces erythropoietin? No. Cerebellar hemangioblastoma, which is associated with von Hippel-Lindau disease, that will produce erythropoietin. It is likely to metastasize to liver? No. They will not metastasize. It is derived from astrocytes? Yes, they are derived from astrocytes. Okay. So these are pilocytic astrocytoma. These are WHO grade 1 tumors. These are derived from astrocytes. Rosettes and pseudo-rosettes are likely to be found microscopically? No. These are found in ependymoma and medulloblastomas. A 44-year-old woman presents with new onset seizure with increasing frequency of severe headache. Medical history is otherwise normal. Physical examination finds bilateral neurological defects. Okay, so now you are having bilateral cortical involvement. Okay, bilateral cortical involvement. Workup reveals a large, ill-defined necrotic mass that involves both right and left cerebral cortex. Okay, so this is the aggressive tumor which is involving both the cerebral cortex. Histology sections from these lesions reveal a hypercellular tumor with pseudo-palisading of tumor cells around large areas of serpentine necrosis. So pseudo-palisading of tumor cells around large areas of serpentine necrosis. So this is the classical feature of glioblastoma multiforme. Okay, I have told you in glioblastoma multiforme, you are going to get serpentine necrosis, and surrounding that you will get the palisading of the tumor cell, that is known as pseudo-palisading of the tumor cells. And grossly, if you see, they will involve both the cortex in a butterfly shape pattern. That is what they have given previously. So it is involving both the cortex. Okay. And these are aggressive tumors. These are WHO grade 4 tumors. You are going to get necrosis. You will get atypical nuclei and mitosis. Okay, so this is a high-grade neoplasm. So what is the diagnosis? Diagnosis is glioblastoma, and you have to remember that glioblastomas are aggressive form of astrocytomas. Okay, it is the most aggressive form of astrocytoma. So answer is astrocytoma. So basically, the WHO grade 4 astrocytoma is called as glioblastoma multiforme. As you can see here, it is involving both the cerebral hemisphere in the butterfly shape pattern, and here you can see there is necrosis. So these are the necrotic areas. These are the necrotic areas, and surrounding that you are finding the pseudo-palisading of the tumor cells. Because these are the necrotic areas, and surrounding that you are finding the pseudo-palisading of the tumor cells. Coming to the next question, a 9-year-old boy presents with progressive severe headache. Physical examination finds paralysis of upward gaze and increased intracranial pressure, which is the result of a mass producing an obstructive hydrocephalus. Okay, so basically here the boy is having difficulty looking upwards, and there is obstructive hydrocephalus. So what is this condition? So they are telling us about a condition that is Parinaud syndrome. Okay, Parinaud syndrome. So in Parinaud syndrome, you are going to get upward gaze palsy, which is otherwise known as the Collier sign. Okay, the upper lid retraction is otherwise known as the Collier sign, which is associated with this Parinaud syndrome. Apart from that, you will also get the convergence retraction nystagmus and the light near dissociation. Those things I have discussed in my video on pinealomas and the Parinaud syndrome. So basically, Parinaud syndrome, it is associated with pineal gland tumors. So pineal gland tumors, by occluding the cerebral aqueduct, they can cause obstructive hydrocephalus, and by involving the dorsal midbrain, they can cause Parinaud syndrome, which is otherwise known as the dorsal midbrain syndrome. So answer is pineal gland. Okay. So I hope this discussion is useful for you. So thank you so much for listening to me.